Hello friends, today I am going to present management of the clinically cN0 neck in oral cancer. I am going to take up some current clinical controversies when it comes to management of clinically cN0 neck in oral cancer. Even after decades of clinical trials, the management of node negative neck remained heavily debated among oncologists. Before I proceed further, let me tell you why is it important to know if the patient has neck metastasis or not. Neck metastasis is the single most important prognostic factor we deal with oral cancer. The moment you find a positive neck node, it completely upstages the disease. This simple finding immediately leads to a massive 50% reduction in overall survival. But the situation can get much worse for our patients. If the tumor breaks through the lymph node capsule, we call it as extracapsular spread or ECS. This dreaded finding causes a further 50% reduction in survival. Finding these positive nodes also means your patient will absolutely need adjuvant therapy like radiation or chemoradiation. The prognosis keeps getting worse based on three main findings: increasing size of involved lymph nodes, total number of positive nodes we find, and the actual presence of extracapsular spread. This is exactly why managing the neck properly is a matter of life and death for our patients. And that is why our understanding about the neck management has to be very clear. There are 7 major areas of controversy that we face in our daily practice. First is skip metastasis in oral cancer. There has always been this strong perception among oncologists that the chances of skip metastasis in oral cancer, particularly tongue cancers, are very, very high. We will decode it today. Second is the imaging to detect cervical nodes. We must ask ourselves, is there any imaging or scan which is truly reliable for picking up cervical nodes in a clinically non-palpable cN0 neck in a patient with oral cancer? Third is the most famous debate of elective versus therapeutic neck dissection in an cN0 neck. How should we treat neck in a patient with oral cancer who is undergoing surgery for the primary and have clinically node negative neck? Should we do neck dissection now, which is called as elective neck dissection, or should we wait and watch and do neck dissection when cervical nodal recurrences occurs in future? We call it therapeutic neck dissection. Thankfully, the debate has closed recently after a landmark publication from TMH Mumbai by Dr. Neil D'Cruz sir. Fourth, we will discuss what is controversy around sentinel lymph node biopsy to manage neck in clinically node negative. Can we replace elective neck dissection with sentinel lymph node biopsy? Fifth, we see if we really need to dissect level 2B and level 4 routinely. What are the pros and cons of doing it and not doing it? Sixth, we evaluate the need for a contralateral neck dissection in a purely lateralized lesion. We must understand when a tumor is likely to cross over and spread to the opposite side of neck. And finally, seventh controversy, in which we will discuss whether neck dissection has to be discontinuous or in continuity neck dissection. Is it absolutely necessary to remove the primary tumor and the neck node in one single continuous piece or a separate surgery? These used to be difficult questions with very significant clinical consequences for our patients. Thankfully, today in April 2026, we have a quite a bit of clarity on many of these controversies. Let us take them up one by one and carefully review what the current evidence tells us. Let us deep dive into the first controversy: skip metastasis in oral cancer, particularly tongue cancer. This is a clinical dilemma, one that routinely comes up during case presentations and viva. There has always been this strong perception among oncology residents that the chances of skip metastasis in tongue cancer are very, very high. But before we accept that, we need to ask ourselves what we actually mean by skip metastasis. We need to be absolutely clear about the term skip metastasis. Clinically, skip metastasis means the cancer has metastasized to the level 4 lymph node completely without involving level 1, level 2 and level 3. Once again, clinically, skip metastasis means the cancer has metastasized to level 4 cervical lymph nodes completely without involving level 1, 2 and 3. We have also given it a term isolated level 4 involvement. The lymph node has literally skipped the first 3 echelon of lymphatic drainage and landed directly in level 4. It is only then that we can accurately call it a skip metastasis to level 4. The critical question is, how often does this actually happen? Look at the slide. I'm showing you a table of various studies that have quoted the prevalence of skip metastasis in oral tongue carcinoma. And right here is the exact mistake that most residents make in their exam. Trainees will almost always point to the very first, oldest and most popular study on this table, the well-known 1997 paper by Byers et al. Remember this author's name, Byers et al. I constantly hear residents quoting this. Everyone will say Byers et al. Had the largest study and demonstrated a 15.8% incidence of skip metastasis. They use this specific number of 15.8% to argue that we must routinely perform a level 4 dissection for these patients. But look closely at the rest of the table. If you look at the more recent studies after Byers et al., the incidence of true skip metastasis is repeatedly reported as close to almost 2% or less. Rather, many of them showing even 0%. So why is there such a massive discrepancy between Byers study and the most recent studies? I want you to look at this study by Byers et al. A little deeply. If you critically evaluate the methodology of the Byers paper, you will realize their definition of a skipped metastasis was highly problematic. In their reported data, the skipped metastasis was not actually in the true absence of level 1, 2 and level 3 all put together. What they actually did was use the mere absence of level 3 nodes to classify a level 4 metastasis as a skip lesion, even if they had level 1 or level 2 nodes. When they counted these patients also, the percentage obviously got inflated to 15.8%. Let me explain this in a simple way. They did not mean that level 1, 2 and 3 were completely free of cancer to be called as skip metastasis. Instead, they used a very misleading criteria. If a patient had cancer in level 1 or 2, but level 3 was clear, and then level 4 was positive, they still counted that as a skip metastasis. They called it a skip just because the disease skipped over level 3. But practically speaking, if level 1 or 2 is already involved, the cancer has already entered the neck. It is not a true isolated skip to level 4. So by combining all these mixed cases, they artificially inflated their numbers to reach that 15.8%. And the whole world took Byers' paper as a gospel truth and started quoting 15.8%. This high number made many surgeons do neck dissection of level 4 also. Examiners will ask you to clarify this 15.8% found in Byers' paper. So be very clear about it. As you see on the right side of the screen, recent studies I showed in previous table shows the true skip metastasis rate is less than 5%, actually 2%, rather some showing even close to 0%. If you look at Byers' paper in more detail, they reported that true skip metastasis in level 4 was reported to be only 3%, very low. So we can say this very boldly that true isolated level 4 skip metastasis is literally unknown. Once again, true isolated level 4 skip metastasis is literally unknown. That means if a patient has level 4 metastasis, it is very high likely that there must be a node higher up in the neck. So as oncologist, you must understand the pathology you are quoting. Do not simply memorize that 15.8% figure without understanding the flawed criteria behind it. To further support this, I want you to look at this retrospective audit published by Tata Memorial Hospital, Mumbai. They asked this exact question: is skip metastasis in early oral cancer a reality or a myth? They evaluated an extensive cohort of 761 patients with early stage clinically node negative oral squamous cell carcinoma between 2016 and 2020. Do you really want to know the actual reality of lower level spread in this massive study? While overall occult metastasis in neck was seen in 17.9% of cases, the incidence of a true skip level 3 was only 1.2%. Yes, you heard it right, 1.2%. And more importantly, the incidence of true skip metastasis to level 4 was a mere 0.3%. Yes, you heard it right, again 0.3%. So skip metastasis to lower neck is a statistical rarity, not a common clinical threat. Why are we so conscious about knowing the percentages of skip metastasis in tongue cancer after all? Does knowing it alter our treatment practice? What difference does it actually make in our daily clinical practice once we understand that true skip metastasis is exceedingly rare? This realization fundamentally changes our surgical approach and radiation approach. For years, based on that flawed data by Byers et al., there was a widespread fear that standard supra-omo-higher neck dissection was simply inadequate. Surgeons worried that only clearing level 1, 2 and 3, they were leaving behind hidden disease. Many argued that we must routinely extend our elective dissections to level 4 for every single patient with tongue cancer. But once we recognize that isolated level 4 metastasis is literally unknown without the prior involvement of level 1, 2 or 3, that fear is completely removed now. This means we can confidently rely on the standard supra-omohyoid neck dissection as an adequate and safe elective procedure for our patients. We can confidently dissect level 1, 2 and 3 only in a clinically N0 neck. Look at the footprint model on the screen. We now know that if the cancer is going to travel down to level 4, it will almost always leave a visible footprint in level 1, 2 or level 3 first. Therefore, we do not need to subject every clinically negative neck node negative patient to a routine level 4 clearance. We can avoid that unnecessary dissection. Instead, some surgeons follow this clinical decision flowchart shown here. We can be much more logical and precise in operating room. If you are operating and send a node from level 1, 2 or 3 for frozen section and it comes back positive, only then we need to continue the dissection level down into level 4. There is another approach some surgeons follow. During your dissection, if they examine level 3 node specifically and find any suspicious node, they send the level 3 node for a frozen section. If that frozen section comes back positive, only then they continue the dissection downward and remove the nodes in level 4. If it is negative, they safely stop at level 3 dissection. So these are some approaches many surgeons use to deal with level 4 dissection. But these are not evidence-based. But yes, they seem logical. Similar rule should be followed by radiation oncologists when they contour neck in a pathologically neck node 0 cases. Do not contour level 4 if the pathological end stage is 0. Do not overtreat. I have stopped including level 4 in my contouring many years ago. So here is the final surgical verdict. By understanding the true pathology, we protect our patient from surgical overtreatment while strictly maintaining our oncological safety. Due to the absolutely negligible incidence for level 4 skip metastasis, clearing the neck up to level 3, our standard supra-omohyoid neck dissection is perfectly adequate for the vast majority of our clinically node negative early oral cancer. The old myth is decoded now. Our surgical extent can be safely optimized to significantly reduce morbidity without compromising the cure. With this, I finished dealing with our first controversy in the management of clinically N0 neck. In my next video, I will deal with second controversy, imaging to detect cervical nodes. Thanks for watching. Stay tuned. Signing off, Parveen Ahlawat.